Lara, thank you for the introduction, and thank you for the privilege of speaking today. I'm going to talk about the autonomic nervous system and the dysfunction of the autonomic nervous system, which is dysautonomia, and how that relates to cranio-cervical instability. So the autonomic nervous system controls all those things that you don't have to think about: cerebral circulation, cardiac function, blood pressure, blood flow to the kidneys and hence urine output, gastrointestinal function, pulmonary secretions, and how the blood flow in your skin is conducted. This is the autonomic nervous system. On the left is the sympathetic system, and this is the fight or flight side of it. If you're going to fight your adversary, you want the sympathetic system that takes away the blood from your gastrointestinal tract and redirects it to your muscles, and it dilates the pupils to improve vision, and it makes you ready for combat. On the right side, and these fibers exit the spinal cord from T1, the first thoracic vertebrae, to the third lumbar vertebrae. That's the sympathetic system. And on the right side are the parasympathetics, and they're composed of two groups: one set of fibers from the brain, the cranial nerves, especially the vagus nerve, cranial nerve 10, and the other set of fibers from the base of the spinal cord, the sacral nuclei S2, S3, S4, and they innervate the bowel and the bladder and the pancreas and stomach to keep those organs, those vegetative functions going. Here, the craniosympathetic nerves, the cranial nerve 10, the vagus, but also cranial nerve 3, the oculomotor nerve, the facial nerve, and the glossopharyngeal nerve, and then the sacral nuclei at the base of the spinal cord. So the parasympathetics are always in balance with the autonomics, with the sympathetics, to maintain a normal blood pressure and functioning of the body without you having to think about it. So here's an abnormal sympathetic function, mydriasis, due to increased sympathetic influence. Through the top of it, the fibers come out of T1, and they run up the side of the spine into the eye to dilate the pupil. And then hyperhidrosis, sweating, and heat intolerance, that's abnormal sympathetic function. And these can be switched on by mental stimuli, and also response to cold or other things. The effect of this is a nervous person who's sweating slightly, a cold sweat. Now, the autonomic nerves have influences on the cerebral blood flow. Most of the regulation is autoregulation. There are intrinsic factors within the brain that respond to the use of the brain. The more you're thinking, the more glucose you metabolize, the more the blood flow. As the pH decreases, as the brain becomes more acidic from activity, as from a seizure, there'll be increased blood flow to that part of the brain. If there's too much blood flow because of cardiac output, excessive cardiac output, the blood vessels in the brain will constrict to decrease that. But through the superior sympathetic ganglia, they can exert vasoconstriction through fibers that run up the carotid artery to the forebrain structures and through the vertebral-basilar arteries to the hindbrain. The parasympathetic nerves also, through the superior salivatory nucleus and other ganglia, can exert a vasodilation effect on the blood vessels to the brain. Now, there's a very important locus in the brain called the locus ceruleus, and if you get a fright, this is the locus that sends norepinephrine throughout your entire brain to immediately alert the entire brain. It sends out norepinephrine. It can be influenced by mental stress and by the hypothalamus. And disorders of the locus ceruleus can cause a panic disorder, anxiety, the flip side, which is depression. It's thought to participate in Parkinson's and Alzheimer's, post-traumatic stress disorder, and ADHD. How does the autonomic nervous system affect the heart? There's an intrinsic control mechanism called the Starling mechanism, where if there's more blood flow coming into the heart, the fibers will stretch and then pump out more, and that can increase the blood flow to about 7 liters per minute. But if the sympathetic fibers kick in with more powerful strokes from the heart and a more rapid heartbeat, it can increase the cardiac output to 20 liters per minute. And these fibers exit the spinal cord in the mid-thoracic spine around T5, T6, and they influence the alpha-1 and beta-1 receptors to increase that power of the cardiac contraction. They also enter the sinoatrial and atrioventricular nodes to speed up contraction. The vagus nerve, on the other hand, sends a branch to the heart and to the same nodes, and it causes an increased potassium release that hyperpolarizes the membrane around the muscle and makes it less responsive to slow down the heart rate. Now, how about blood pressure? The autonomics have stretch receptors in the carotid and the aortic arch and in the heart, and these stretch-sensitive mechanoreceptors exert a split-second negative feedback to maintain a normal blood pressure. So if you have a high blood pressure, sensory fibers send a signal up to the nucleus solitarius, and that exerts a excitatory effect on the thalamus, that exerts a inhibitory effect on the rostral thalamus, that inhibits the hypothalamus, that results in inhibiting the sympathetic output. That inhibition is then exerted down through the spine, through the sympathetic plexus, the autonomic nervous system, to lower the blood pressure. Now, if there's a decreased blood pressure, there's less firing of the nucleus solitarius and decreased inhibition of the thalamus and so on, and that results in an increase in stimulation of the sympathetic fibers to speed up the heart and also to stimulate renin production in the kidneys to increase sodium reabsorption. So the sodium reabsorption increases blood volume, and that increases the blood pressure. Now, the airways are controlled also by the autonomic nervous system. The vagus nerve in particular stimulates these M cells to cause bronchoconstriction and mucus production, but they're controlled by two fibers, the A delta fibers, which are sensitive to smoke and histamine and serotonin, and also the C fibers. And these C fibers, once stimulated, then trigger the vagus nerve to cause mucus production, constrict the airways, cause asthma-like symptoms, many of which are similar to what Ann Maitland has been discussing. They also increase vascular permeability. They can cause leaky blood vessels, increase mucociliary activity. Now, almost every patient with EDS has GI problems. And we know the seventh, the facial nerve and the glossopharyngeal nerve trigger salivation from the salivary glands, and the vagus nerve triggers gastric acid release and pepsin, and also triggers the pancreas to produce trypsin, amylase, lipase, protease necessary to digest food. And the cholecystokinin helps to contract the gallbladder. Then the vagal nerve stimulates all of the bowel, all of the small intestine, and all of the large intestine to the splenic flexure. That's the point of the large bowel right under the spleen on the left. And thereafter, it's the sacral nucleus at S234 that governs the function of the GI system below, down to the rectum. So the vagus is therefore the major innervator of the bowel, but it needs the sacral parasympathetics as well for gastric emptying. These vagal fibers stimulate plexi, a nerve plexi within the bowel wall to stimulate both the contraction of the bowel and also the blood flow through the bowel. At the same time, the sympathetic fibers are there, and if the adrenaline level increases, you see a decreased blood flow to the bowel, decreased absorption, maybe more diarrhea, and less contraction of the bowel and gastroparesis. So we see the parasympathetic system then predominantly governing the GI system. And when that's out of whack, we see dysphagia, difficulty swallowing. We see gastric reflux. We see gastroparesis, malabsorption, bloating, constipation, and incontinence. Raynaud's phenomenon occurs when there's abnormal autonomic function to the skin, abnormal blood flow. So in response to cold or stress, the hands may turn red and sweat a bit, and this is Raynaud's phenomenon. It can also cause a chronic regional pain syndrome that Dr. Chopra will have much to say about. We see a lot of syncope with dysautonomia. The Framingham study in Connecticut found that 3% of men have syncope and 3.5% of women will have syncope at some point in their life. This is all men, all women. And it's due to activation of an inhibition vasodepressor reflex, and also due to orthostatic hypotension or acute decreases in cardiac output or increased in resistance peripherally. Syncope, turns out, occurs commonly with Chiari malformations. And we know that Chiari seems to occur a little more often, more frequently with connective tissue disorders than the general population. Syncope occurs with postural orthostatic tachycardia, which is present in 3/4 of the EDS population, and it's probably the most disabling manifestation of EDS. Now, in postural orthostatic tachycardia syndrome, there's a high resting sympathetic tone. So the level of adrenaline is generally higher in the EDS patient. But then when you really need the adrenaline, there's less of a response. They're less able to activate an adrenaline response to a sudden drop in blood pressure. On the other hand, they have normal parasympathetic regulation. So POTS is primarily a problem of the sympathetics, not the parasympathetics. So typically we see on the tilt table, for instance, or maybe just a patient standing up, there'll be a sudden rise in the heart rate of 30 beats per minute, and that's POTS. Or there'll be a sudden drop in blood pressure, and that's neurally mediated hypotension. And to some extent, this is due to pooling of the blood in the lower extremities, and to some extent, the abnormal adrenal sympathetic vascular response to drops in blood pressure. Now, there are many causes of dysautonomia, hereditary conditions like Riley-Day, autoimmune conditions, lupus, sarcoid, MS, N-methyl-D-aspartate receptor encephalitis, HIV, Guillain-Barré, fibromyalgia, asphyxiation, injuries to the peripheral nervous system like diabetes or Lyme's, mitochondrial disorders, degenerative conditions. And the last three are really pertinent to hereditary connective tissue disorders, chronic trauma to the nervous system, hypermobility, and brainstem deformity conditions. So where does this occur? It's not just the brainstem or the brain, it's every aspect of the nervous system, from the center of the brain all the way out to the small nerves in the skin. What are the brainstem nuclei? I've talked about the dorsal motor nuclei and the nucleus solitarius, very important for governing heart rate and blood pressure. Nucleus ambiguus in pulmonary breathing and speech, actually. So our hypothesis is then the biomechanical deformity of the cranio-cervical junction is going to alter autonomic activity. And so what am I talking about by mechanical deformity? I'm talking about structural and dynamic. So here's a Chiari malformation. The cerebellum pushing down through the foramen magnum, causing pressure on the brainstem and lower and upper spinal cord. And in Doug Brockmeyer's paper, looking at 100 decompressions, 20% of those Chiaris also had an odontoid in the front pushing backward into the brainstem, or a kyphotic clival axial angle causing strain in the brainstem. Odontoid pannus is the inflammatory inflammation around the lining of the spinal canal that can, if it gets thick enough, can compress the spinal cord. Platybasia is a flattening of the skull on the spine, and you can see here how it compresses the base of the brainstem. Here's a patient with rheumatoid arthritis, and the odontoid is pushing up through the base of the skull, compressing the brainstem. And this is a patient with what's called assimilation of the atlas, where the C1 fails to separate from the skull. It's also called a HOXD3 homeotic transformation. And that can cause instability and compression of the brainstem. Now, sometimes we do a decompression for a Chiari and we remove enough stabilizing elements that we create instability, as in this case, where the instability now is resulting in compression against the front of the brainstem following a decompression for a Chiari. So there are 50 connective tissue disorders. EDS is the most common. We tried to gather many of the neurological and spinal problems together in this publication, which has been made available to you free online if you want to pull it up. So why would deformation of the central nervous system alter neurological function? And this is how I first got into this whole problem. When I was in London, England, doing a fellowship, I looked at 10 patients who had died of compression of the brainstem from rheumatoid arthritis. And the professor said, you'll find signs of ischemia. But what I did find was not ischemia, but these silver staining things here. And they are axon retraction balls, and they're the result of straining and stretching. That's a biomechanical problem. And no one believed me at the time. We did publish that, but a few years later, PublicShock looked at electron microscopic views, and he showed that with stretching of the neurons, there's dissolution of the neurofilaments, the architectural elements of the axon, and loss of the microtubules, so that the axoplasm, the normal flow down the axon, would stop and bunch up, and that would form an axon retraction ball, and that would precede the dissolution of the nerve, or axontomesis. And Satman showed if you stretch a mouse optic nerve 20% of its length, that a few days later you get these same axon retraction balls, and later you get apoptosis, or death of the nerve. And Wolf showed that if you stretch nerves, that it alters the flux of the sodium through the nerve, that maintains the electrochemical gradient, leads to a massive calcium influx and injury to the nerve from that. And importantly, Arendine showed that if you stretch nerves, there's actually an epigenetic phenomenon where the stretch causes upregulation, causes the gene to produce more of certain proteins, for instance, N-methyl-D-aspartate, which is a learning hormone, but also makes the nerve more sensitive to nitrous oxide and free radical species, and can trigger cell death. So we published also a series of 12 patients who had severe Atlanto-axial dislocation, and they all had sleep apnea. And when we decompressed the brainstem and spinal cord, the sleep apnea went away. And then in 2010, we looked at this from an engineering point of view, and we developed a finite element analysis model, a mathematical model of the brainstem and spinal cord to mathematically predict whether the stretching and deformation would reach pathological levels. And in this study, we applied traction, and we straightened out the neck, and the idea being to restore a normal, if you look on the picture on the right there, you see a stretched brainstem, and by performing the reduction, we established a more normal picture on the left with no strain. This is a finite element analysis technique we used that gave us very nice color pictures that denoted the strain in the brainstem and spinal cord. And here's a young patient who was 9 years old, and he'd been to the emergency room every week for a year after he stopped breathing or his heart would stop, and no one could work out what the problem was. This was only 20 years ago, 18 years ago. And the mathematical analysis, the FEA showed extremely high strains in the brainstem. And after the surgery, which is reduction, fusion, stabilization, the finite element analysis showed no strain. And he did wonderfully. He went on and went on to college, full scholarship on aviation, aerospace, mathematics, and physics. When we looked at all of these patients, their improvement in sensory motor and Kanofsky performance scores and the physical and mental component quality of life scores were all substantially improved, and they also correlated with the improvement of the mathematically predicted stresses and strains in the brainstem and spinal cord. Now, I wanted to present our data from that was just published in January in the Neurosurgical Review, and it's made available to all of you at no charge. You can pull it up online. It was retrospective, IRB approved, 20 subjects, mostly women. Almost all had Chiaris, all had, of course, connective tissue disorders. A third party performed the online survey. I did the exam. We had 20 out of 20 responding at 2 and 5 years. Indications for fusion were severe headache, neck pain, neurologic deficit, cervical medullary syndrome, neurologic deficit referable to the cranio-cervical junction, and congruent radiological findings. So we wanted at least 2 of the radiological criteria present. And what were they? There's the Chiari malformation. That was an important criteria. Or a kyphotic clival axial angle of less than 135 degrees. Or ventral brainstem compression as a cause of neurologic deterioration. This is an abnormal Harris measurement where the skull has slipped forward on the spine and causing traction on the brainstem. Or the presence of Atlanto-axial instability. And the operative procedure for these patients included exposure of the skull base, removal of the base of the skull to decompress the Chiari and make more space for the cerebral spinal fluid. And then we put in screws, a plate on the back of the head, and performed intraoperative traction. So by this, we pull on the head and move it backwards or, extend it, and this makes the patient taller, better looking, and not that that's needed, and restores the normal configuration of the central nervous system. So here's the reduction. We establish a normal clival-axial angle, a normal mandible to axial interval so the patient can swallow afterwards, a normal gaze angle. This is the orbital axial angle that we've developed so the patient has the appropriate gaze angle. If they're very tall, it's a little less. If they're short, it's a little bit more. So the symptoms prior to surgery, all the Usual suspects: headache, dizziness, arm pain, neck pain, imbalance, memory, gait, numbness, Raynaud's, all those things. These are the cervical medullary syndrome. These are symptoms that we anticipate you'll get if you compress or deform the lower brainstem or upper spinal cord. Now, the fusion rate was 100%. We were able to increase the clival-axial angle more than 20 degrees, and we asked the patients at 2 and 5 years, looking back, would you still do the surgery? And they all agreed with varying degrees of enthusiasm. And the surgery improved my symptoms and decreased my limitations. Two patients had so many other problems that it did not improve their symptoms. Average headache went from 8 in red before surgery to about 4 at 2 and 5 years. Now, so the dysautonomic symptoms improving after surgery included syncope, headaches, balance, dizziness. The things that did not seem to improve that much, and maybe our sensitivity wasn't good enough to pick it up: the Raynaud phenomenon, hands and feet turning cold, fatigue, GERDs, nocturia, irritable bowel syndrome, small improvements there. Kanofsky performance, 0 is dead, 100 is normal, and the Kanofsky score went from an average 50 before surgery to 78 after surgery, highly significant. So that was that study. And now I want to show you some more recent data where we're looking at improvement of dysautonomia after stabilization of C1, C2. And all of these patients had syncope and very bad dysautonomia. Now, these are only preliminary results because we did not have all the data in yet. I hope to have it in by the end of August. I'm doing this study with Peter Rowe and Claire Francomano. So C1-2 instability, as you know, is a slippage, a subluxation of C1 upon C2. Normally, when you turn your head, there'll be a 25 to 35 degree angulation between C1 and C2. More than that, and you're getting into problems. And around 35 to 40, you start compressing one vertebral artery and decreasing flow. And above 40, you're leading to obstruction in both vertebral arteries. So Atlanto-axial subluxation is quite common in rheumatoid arthritis, at least before the introduction of the new drugs like Enbrel. And in JRA, lupus, Down syndrome, very common, ankylosing spondylitis, myxedema, hyperparathyroidism, and skeletal dysplasias. And there's a picture of one vertebrae slipping off the other, and you can see just a little bit more turn, and that would be a dislocation there. So in this study, we've sent out questionnaires to 20 patients, third party performing an online survey, so free from my influence, hopefully, and the radiological measurements and neurologic exam by Dr. Kirby, neurologic exam by me. And these patients had the full panoply of symptoms that we see: the headaches, vertigo, lightheadedness, dizziness, fatigue, the nausea, weakness, exercise intolerance, presyncope, orthostatic hypotension, and so on, so on. Our indications for fusion here were a little different. Headache or neck pain, 7 or above. And all of these patients had syncope or presyncope, occipital neuralgia, like headaches that began in the back of the head, would often radiate behind both orbits. Visual changes, they often describe a blurring in the peripheral vision, a tendency to walk into door frames, I think because they don't see them, walking into other people. And also dysesthesias, painful numbness in the hands and sometimes legs that come and go. Now on exam, if you stick them with a needle, they'll feel the sharpness, but there's no pain. So there's that hypoesthesia that's throughout the body. And the reflexes are very brisk, and there's tenderness over C1 and instability by CT. And we get the CT exam. We make the diagnosis by stressing the alar ligament in a CT scanner, tilting the head to the right and left. And then here you see on the left is the C1 rotated to the side 85 degrees, and the C2 is rotated 40 degrees, so the difference between them is 45 degrees, and that's very unstable. So on the upper left, you see a joint almost dislocated. Upper right, you see a 3D CT showing very little coverage of that facet joint, and then the fusion below, which is the treatment. So what symptoms improved? Syncope, now this is preliminary data, 100% improvement in syncope severity, 66%, two-thirds with pre-syncope enjoyed an improvement in severity, 83% improvement in exercise tolerance, 80% improvement in orthostatic hypotension frequency and severity, improvements in vertigo, headache, lightheadedness, anxiety, lightheaded. So we saw improvement in the orthostatic hypotension. We won't, and also here there was a significant improvement in the Raynaud type phenomenon and chronic regional pain syndrome. So of the patients who have sent their data back in, all of them strongly agreed that they would choose to have and that should read Atlanto-axial fusion surgery. Having this surgery improved my symptoms and decreased my limitations. One of the patients disagreed because of the presence of many other conditions. Red is the pain before surgery, and you can see the degree of severe pain decreased significantly after surgery in green, and there's more mild and moderate pain. Similarly with lightheadedness and the degree of syncope, pre-syncope, and orthostatic hypotension. Using the orthostatic grading scale, you can see that before surgery in red, the patients most of the time had orthostatic symptoms. After surgery, the symptoms were much less frequent, shown in blue. 1 is sometimes, 2 is often. And similarly with the orthostatic grading scale, these are just different measurement scales, and they show a significant improvement in activities of daily living. So the patient's impression of global change, most were moderately or definitely better, and 1 was no change or worse. And the Konofsky performance, again, before surgery, the average was approximately 60, and afterwards, the average was 80. So we saw significant improvements in dysautonomic symptoms after correction of deformity and stabilization in syncope severity, pre-syncope severity, chronic regional pain syndrome, exercise intolerance, orthostatic hypotension, vertigo, headache, lightheadedness, anxiety, sleep apnea. So, in conclusion, the autonomic nervous system is anatomically ubiquitous. It's throughout the body. It's stratified. It's complex. It occurs frequently with the hereditary connective tissue disorders, and that's an understatement. It's strongly associated with conditions of instability and deformation of the brainstem, and it shows some improvement after reduction of deformity and stabilization. I'd like to acknowledge my coworkers and thank you for your attention.
Okay. What type of hardware, shape and fixed points?
Can I just say that I'm going to plead like Muller. If it's not in my report, I can't answer the question.
Okay. Should we give it a go?
Oh, go ahead. Go ahead.
Okay. What type of hardware?
Actually, that's Director Muller. I have great respect for him.
What type of hardware is used during the fusion process, and how long does it last?
Well, the hardware lasts forever. It's titanium. In that first series I showed you with cranio-cervical fusion, a number of patients had pain from the screws, and so, several 3 to 5 years later, I took out the hardware in a number of patients. But generally speaking, you leave it in there for life. For the last couple of years, I've been using much lower profile hardware, and we've not had, it's very seldom that I ever take out any hardware now.
What is the typical workup you would recommend for an EDS patient with neck pain, lightheadedness, nausea, occasional migraine? Is there anything specific you need to ask a neurologist to check for?
Well, I mean, that's every patient with Ehlers-Danlos syndrome. So, you need to hit the straightforward things, well, nothing straightforward. Physical therapy, maximal treatment of your postural orthostatic tachycardia with midodrine, and exercise regimen, and doing all of those things. The surgeon should be the last person that you want to see. Was your question directed to what kind of studies that a neurosurgeon would want to see?
Yeah, what
Okay.
would you ask the neurologist to check for?
The studies we like to see are a flexion extension, CT scan or MRI of the cervical spine, and preferably that's an upright MRI, but if you don't have access to an upright MRI, you can lie on a table and put a pillow under your shoulders and extend your neck, and then put the pillow under your head for a flexion view. So that's another way to get a flexion extension view. And so ideally there's a MRI flexion extension, and then a CT or a CT scan flexion extension. And to rule out C1-2 instability, we like those CT scans where you lie on your back and turn the head full to the right and then turn full to the left. And that stresses the alar ligament and shows up alar ligament incompetence.
Can hearing loss from CCI improve with stabilization?
Sorry.
Could hearing loss from CCI...
Yeah, is there a surgeon in the audience? I think yes, and I haven't looked at that specifically, but many patients enjoy improved hearing after surgery, and we do evoked potentials of the brainstem auditory evoked responses, and very often they're very delayed in patients at the beginning of surgery. And I think it's due to stretching of the nerves and many other factors. And I believe we do see improvement, but I can't give you a statistic on that.
With the increased discussion about this on forums and social media, should EDS patients be screened for Chiari automatically, because there is a fear now out there that that is what all EDS patients have? And if not, what are the largest red flags for people to watch out for?
Yeah. 5 or 6 years ago, I thought that if you have cranio-cervical instability in a Chiari, you should have it decompressed and fused and stabilized all at the same time. And now I've swung back a bit, and if you need a Chiari surgery, have the Chiari surgery. If you should definitely get the flexion extension views to make sure you don't have, severe instability. But I think that there are many EDS patients who can get a suboccipital decompression without having to have the fusion stabilization. So it's reasonable to separate the two surgeries, unless it's clearly obvious that you have cranio-cervical instability.
But I think also the question is it should really only be when there's symptoms, rather than if there's not, as a precaution.
Sorry, could you repeat that again?
So I think people are saying, should everyone with EDS be screened for Chiari? Or should you just do it if you have symptoms?
Yeah, only if you have disabling symptoms, yeah. Because even if you have a Chiari, it doesn't mean you need surgery. I mean, and I'll show you in my next lecture at 3, that the many patients I follow who have some instability, who have Chiaris, and I don't operate on them. And so I wouldn't even bother working it up until you're clearly getting disabled, yeah?
Has there been any gained knowledge or as to the benefit as whether to open the dura or not during decompression surgery?
I do it always. Generally speaking, I don't think it's necessary to open the dura in most cases. And so I do that. I only do that on very big Chiaris, and sometimes I'll remove part of the Chiari malformation. But most of the time, all it needs is especially in the EDS population, more space for CSF flow, and you do not need to open the dura.
Will a CSF leak cause POTS or be confused with POTS?
Sorry, could you say that again?
Would a CSF leak cause POTS or be confused with POTS?
Oh, yeah. The simple differentiation for CSF leak is you stand up, and after 1 or 5 or 10 or 30 minutes, you get a horrible headache and nausea. You feel horrible. And then you lie down, and over the course of the next hour, you feel better. That's intracranial hypotension. Now, POTS, of course, POTS can do operate in the same way. So the tilt table would help differentiate it. But really, with POTS, you'll see the rapid change in heart rate or the change in blood pressure that will differentiate it from intracranial hypotension. So spinal headache, you're not going to drop your pressure. You're not going to exhibit a rapid heart rate.
Okay, that's all we have time for. Thank you so much to Dr. Henderson.